Let's start with a few words about the anatomy. So kidneys are retroperitoneal, left kidney is higher, blood vessels, renal arteries supply, renal veins drain, so renal arteries originate from aorta, renal veins drain in the inferior vena cava. The point of entrance is a hilum, vessels that drain urine, ureters, and the filtrate goes into the urinary bladder. The function of urinary bladder is storage and expulsion, and urine leaves urinary bladder through the urethra. Urinary bladder is anterior to the rectum, and in females it is inferior to uterus. Main anatomical layers that form kidney are medulla and cortex. Cortex is superficial, medulla is deep. Structural elements of cortex are renal columns, and structural elements of medulla are renal pyramids. Renal pyramids produce urine, which exits renal pyramids at the renal papilla. From renal papilla, urine drains into the minor calyx. From minor calyx, basically it's a small cavity. From minor calyx into the major calyx, and from major calyx it gets into the renal pelvis, and from renal pelvis it drains into the ureters. So what we just described is the flow of urine through the kidneys to the ureters. I keep saying that same. From medulla to ureters. The main functional unit of a kidney is a nephron. The main parts of it are glomerulus, that contains a glomerular capsule and glomerular capillaries, proximal convoluted tubule, nephron loop, distal convoluted tubule. In glomerulus, there is filtration. In proximal convoluted, in tubules, absorption and secretion. Absorption goes on mostly in the proximal convoluted tubule and in the nephron loop. So the pathway of filtrate through the nephron is generated in the glomerulus. From glomerulus it drains into the proximal convoluted tubule, then goes into the nephron loop. From nephron loop it gets into the distal convoluted tubule. From distal convoluted tubule it enters the collecting duct. From collecting duct into minor calyx, and so on and so forth. So three main steps we already described: filtration, reabsorption, and secretion. So filtration occurs in the glomerulus, and during the filtration, basically all chemicals, water, smaller organic molecules, ions, are filtered from the glomerular capillaries into the glomerular capsule. In the reabsorption, those same chemicals are reabsorbed back from the filtrate into the blood, and reabsorption occurs mostly in the proximal convoluted tubule and the nephron loop, and secretion occurs in the distal convoluted tubule mostly, and during secretion chemicals are secreted again from the blood into the filtrate. Now there are two main nephrons in a kidney, you remember that. One is cortical nephron and one is juxtamedullary nephron. So cortical nephron is located mostly in the cortex, and its nephron loop, its proximal, distal convoluted tubule, and nephron loop are surrounded by the capillaries that are called peritubular capillaries. Juxtamedullary nephron is located at the border between the cortex and the medulla, and its nephron loop is surrounded by capillaries that are called vasa recta. Cortical nephron is responsible mainly for electrolyte balance, filtration and reabsorption of various ions and organic molecules, while juxtamedullary nephron is mainly responsible for the regulation of the urine concentration. The main structural elements of glomerulus are glomerular capillaries and glomerular capsule. And there are two arterioles, one that delivers the blood to the glomerulus. It's called afferent arteriole, and one that is draining the blood from glomerulus, which is called efferent arteriole. Afferent arteriole is wider than efferent arteriole, and the consequence of the difference in the diameter is that the blood pressure in the glomerular capillaries is higher than in normal capillary beds. That's what makes one of the things that makes this capillary bed quite unique. And that increased blood pressure facilitates the process of filtration in the glomerulus. Three pressures and filtration in the glomerulus is guided by net filtration pressure, which is formed by three pressures. One is called capillary hydrostatic pressure. So that's basically a pressure that's exerted by the blood on the wall of glomerular capillaries, and it is proportional to the blood pressure. So this capillary hydrostatic pressure, it moves the fluid from the filtrate into the blood. Sorry, from the blood into the filtrate. Then there is capsular hydrostatic pressure exerted by filtrate in the capsule, glomerular capsule, and it moves the fluid from the filtrate back into the blood. And then there is capillary osmotic pressure, which depends on the concentration of protein in the plasma, and capillary osmotic pressure pulls the fluid from the filtrate into the blood as well. So I'm going to stop sharing the screen for a moment. And I hope you see the whiteboard on your screens, because this is what it's going to look like. So this is blood, this is filtrate, and that is capillary hydrostatic pressure. That is...
Dr. K, it went back to the normal screen.
It went back to normal?
Yeah. Yeah, we're like looking at you.
Can you see me in front of the...
Yeah. Yeah.
In front of the whiteboard?
Nope. I see you looking.
Can you see my hand in front of the whiteboard?
No.
How about now? Can you see me in front of the whiteboard?
Kinda, you're tiny. Yeah, it's not the main screen. Okay, so it isn't just me.
Yeah, you can.
I can see what the normally it, and then
change the appearance in the upper right corner, and you can change like active speaker video view. If you move your cursor to the upper right corner, it will not be agreed, but just so basically what I wanted to show you here is that if we have blood filtrate, then that's going to be hydrostatic capillary, that's going to be capsular capillary pressure from glomerulus, and that will be capillary osmotic pressure. So just to keep in mind what the directions are. That makes sense. I hope it makes sense. So let's go back to this one. So those are three pressures. We already discussed where each of these pressures moves fluids. And there's no capsular osmotic pressure because normally there is no protein in the filtrate. Now the net filtration pressure essentially drives, I'm not going to ask about the numbers. Net filtration pressure will drive the fluids from the blood in the capillary into the glomerular capsule. So net filtration pressure changes when blood pressure changes. If blood pressure increases, then hydrostatic capillary pressure increases and NFP increases. Blood pressure goes down, NFP goes down. Now, if concentration of albumin increases, then osmotic pressure will increase, meaning that if there is more albumin in the blood, NFP will become lower, and vice versa. And if albumin appears in the filtrate, then out of a sudden, you will get a capillary pressure, sorry, not a capillary, osmotic pressure that is, it's not normal. And then NFP will increase if albumin appears in the filtrate. Now, fenestrated capillaries form glomeruli. Two distinctive features of the glomerular capillary bed is that first, it is supplied and drained by arterioles. Usually, remember, capillary bed is drained by venules. And second, it has unusually high blood pressure in that capillary bed. Now, podocytes are the cells that surround glomerular capillaries. So they're located just outside of the glomerular capillaries. And food processes of these cells form so-called filtration slits, little fissures that allow certain molecules to pass through. And basically proteins and anything larger than proteins cannot pass through the filtration slits normally. So glomerular filtration rate is the amount of filtrate that is formed in 1 minute. Three factors that determine it is net filtration pressure, the surface of the filtration membrane, and the permeability of the filtration membrane. So permeability and the surface are usually high, and physiological parameter that mostly affects GFR is blood pressure. So blood pressure mostly defines net filtration pressure in the GFR. There are two types of the controls in the kidney. Intrinsic controls, their goal is to control GFR, maintain it constant. The goal of the extrinsic controls is to maintain blood pressure at the expense of GFR. And if blood pressure changes dramatically for an extended period of time, extrinsic controls override intrinsic. So if blood pressure goes significantly down because of the blood loss, for instance, then maintenance of normal GFR is not an issue anymore. So if blood pressure rapidly decreases, GFR decreases, and if that decreased blood pressure stays low for an extended period of time, lower GFR means no proper filtration. No proper filtration means no proper maintenance of the ion concentrations in the blood and extracellular fluid, and it may lead to the accumulation of toxins in the circulation. Before we move any further, any questions so far? We're good? Okay. Okay, I'm going to do this. It's better because now Okay, two main mechanisms for the intrinsic controls of GFR are myogenic and juxtaglomerular. So myogenic control, as I discussed in one of the whiteboard videos that I recorded, when blood pressure, for instance, increases, GFR increases, and increased blood pressure also exerts additional stretch on the arteriolar wall. And afferent arteriole, in response to increased stretch, constrict. So afferent arteriole, in response to increased stretch, constrict, and efferent arteriole, dilate. These two responses decrease the blood flow through the capillary bed, and that decreases GFR. And vice versa, if blood pressure goes down, GFR goes down. In response to reduced stretch, afferent arterioles dilate, efferent arterioles constrict, blood flow and blood pressure in the capillary bed increases, and GFR increases. Okay? So this myogenic response, does it make sense for you? You can unmute yourself. If nobody says anything, I presume that kind of does. Excellent. Now, macula densa cells are the cells that sense the concentration of sodium in the filtrate. Juxtaglomerular cells, cells that produce renin and can also constrict and dilate afferent arteriole. And these two cells, macula densa cells and juxtaglomerular cells, communicate with each other by mesangial cells, which have gap junctions, making it possible. The communication is made possible basically by these gap junctions. So these three cells, macula densa, juxtaglomerular, and mesangial cells, participate in what is called juxtaglomerular mechanism regulating GFR. So when blood pressure increases, GFR increases as well. When GFR increases, the flow rate of the filtrate also increases. When filtrate flows faster through proximal convoluted tubule and nephron loop, the time for reabsorption goes down. And if time for reabsorption goes down, then reabsorption goes down, which immediately increases the concentration of sodium chloride in the filtrate. That elevated concentration sodium chloride in the filtrate is sensed by macula densa cells, which then communicate to granular or juxtaglomerular cells to constrict afferent arteriole. Constriction of afferent arteriole decreases the blood flow and blood pressure in the glomerular capillaries. Decreased blood flow and blood pressure leads to the decreased GFR, and basically it all goes back to normal, typical negative feedback regulation. So we basically just answered that question, okay? So when
I have a question.
Sure.
So, for the granular cells, did you say efferent or afferent?
Afferent.
So both myogenic and the other one, they both control afferent?
Myogenic response affects both afferent and efferent arterioles,
Okay.
just in a different way. So for instance, in response to increased GFR, in myogenic response, afferent arteriole will constrict, while efferent will dilate. In juxtaglomerular response, in response to increased GFR, afferent arteriole will constrict, period.
Okay.
Did I answer your question?
Yeah, thanks.
You're welcome. So when afferent arteriole constricts, GFR goes down, which reduces the filtrate flow rate, which increases the reabsorption time, which decreases the sodium chloride concentration. So basically, it's another example of, again, of teeter-totter regulation here. Decreased blood pressure. Now, here's the thing. This part, well, specifically this part, talks about the same things as these three lanes, okay? Same exactly story, you just need to flip all the increases, decreases. Everything goes in the opposite way. Now, in response to low blood pressure, granular cells not only dilate afferent arteriole, they also produce renin. And as you remember, renin will start the whole renin-angiotensin aldosterone system. Now, main mechanisms for the extrinsic control of blood pressure. So let's talk about some of them. Sympathetic responses. When blood pressure drops, sympathetic responses get activated. That leads to the release of epinephrine, norepinephrine. Release of epinephrine and norepinephrine leads to the constriction of afferent arterioles. When afferent arterioles constrict, blood flow through the glomerulus also drops, which means less filtrate is formed. So less filtrate is formed. Since less filtrate is formed, blood volume goes up, blood pressure goes up. Remember, now we are talking about the extrinsic controls, controls that maintain blood pressure at the expense of GFR. Now, in response to sympathetic system activation, granular cells produce renin. Renin activates angiotensin. Angiotensin activates aldosterone, and aldosterone increases the sodium retention and water retention, which increases blood volume and blood pressure. And remember, we are talking again about the regulation of lower blood pressure. Any questions so far about filtration? Okay, good. Moving on. Now, main driving force behind reabsorption. I made this picture before. You've got an epithelial cell, sodium-potassium pump. Sodium-potassium pump pumps sodium out of the cell, which means the sodium concentration in the cell is pretty low. And then you have sodium channels on the apical side. So it's apical side, that is basal side. You have sodium channels on the apical side, and sodium freely diffuses. Not freely, but diffuses through the channels from the filtrate into the cell. And from the cell, it is constantly being pumped into the extracellular fluid. So essentially, you create a flow of sodium across the tubular epithelium, which then facilitates all other reabsorption events. So sodium-potassium pump here is located on the basal side of epithelium, pumping sodium out of the cell and potassium into the cell. So intracellular concentration of sodium in the tubular epithelium is lower than the filtrate. Now, sodium ions from the filtrate, they diffuse into the epithelial cells, and then sodium reabsorption is essentially driven by that low sodium concentration. Now, water is reabsorbed through the osmosis, and again, the driving force for it is constant reabsorption of sodium. So sodium moves from the filtrate into the blood, and water basically follows. So other ions how they are reabsorbed. So we have sodium flow, and concomitant with that, we have flow of other ions. Let's say it's calcium. So it's calcium, sodium, sym-porter. We call it a secondary active transport. Sodium diffuses. Diffusion of sodium releases diffusion of sodium releases kinetic energy, which is then used to reabsorb against the concentration gradient other ions. So that sym-porter situation right here is an example of transcellular route for reabsorption. But there is also paracellular route where there's reabsorption between the cells. So during transcellular reabsorption, ions have to cross the sym-porter on the apical side of the epithelium and the channel on the basal side. For sodium, it's going to be the other way around. Now, in paracellular reabsorption, the situation is quite different. When water is reabsorbed from the filtrate, the concentration of ions in the filtrate goes up, which means suddenly the concentration of ions in the filtrate becomes higher than the concentration of ions in the extracellular fluid, and they can diffuse between the cells from the filtrate into the extracellular fluid. So this is paracellular reabsorption, which does not require any transmembrane proteins, whether those are pumps or channels. Before we move on to transport maximum, does that make sense? Any questions? So what is the transport maximum? Since ions have to use transmembrane proteins, these transmembrane proteins, whether those are pumps or channels, they have limited capacity in terms of how many ions can pass through those in a given time, in a minute, let's say. So if at some point the increase in concentration of a certain ion in the filtrate right here will not be able to affect the amount of ion that will be reabsorbed, because there is just not enough channels to provide significant reabsorption. So this is what we call a transport maximum. If you draw a graph and you have a filtrate concentration on the x-axis and the reabsorbed amount, let's put it reabsorbed amount, on the y-axis, there's like multiple, anyway, so you increase the concentration of ion in the filtrate and it gets reabsorbed, but then when it reaches transport maximum, it's not reabsorbed anymore. So this is going to be the reabsorption. Now what's going to happen if you keep increasing the concentration of ion in the filtrate? This dotted line, dashed line, represents that difference, represents the amount of chemical that will be excreted on top of transport maximum with the urine. So it is best illustrated by the process that happens in people with diabetes whose blood glucose is extremely high. It gets filtered and then it gets reabsorbed, but that can be reabsorbed only to a certain extent. All glucose that cannot be reabsorbed due to this transport maximum constraints will be passed out with the urine, and basically you can, if you can detect your high glucose concentrations in the urine, you can say, okay, this person has diabetes. Physiological any questions? Okay. Physiological purpose of secretion: to get rid of the stuff at the very last minute, like drugs or potassium. For instance, potassium secretion is regulated by aldosterone. Aldosterone directly stimulates the secretion of potassium. Secretion, why it is important for the urea disposal? Because we want to dispose of the urea essentially, and it's fully reabsorbed, usually via paracellular route, in the ascending limb of the loop of Henle. So at some point, usually in a distal convoluted tubule, urea is secreted again because the disposal, Now, a few words about the regulation of urine concentration. Osmolality is the total concentration of all particles in the solution. So osmolality does not refer to iron, to sodium, potassium, calcium, urea, it doesn't matter. Total summary of all concentrations. So basically, the more concentrated solution is, the higher the osmolality of it. So from superficial to deep medulla, osmolality increases. And in deep medulla, it's much higher than osmolality of plasma. In a superficial medulla, it's basically equal to it. So juxtamedullary nephrons are responsible for the regulation of urine concentration. So nephron loop is countercurrent multiplier, and vasa recta is countercurrent exchanger. Function of the countercurrent multiplier is reabsorption of sodium chloride and water. Basically, it's the site for obligatory reabsorption of water and sodium chloride. The function of countercurrent exchanger is to take away reabsorbed sodium chloride and water and to maintain osmolality in the medullary extracellular fluid. So when filtrate enters the descending limb of nephron loop in juxtamedullary nephron, the filtrate osmolality is 300 milliosmoles. You don't need to memorize the numbers, but you need to be able to compare. So in the descending limb, water is reabsorbed from the filtrate, and this is the obligatory process. So when water is reabsorbed, the concentration of filtrate goes up while its volume goes down. So at the very bottom of the nephron loop, right here, the osmolality is the highest. And that's the direction of the filtrate flow. Now, in the ascending limb of the nephron loop, sodium chloride gets reabsorbed. That decreases the osmolality of the filtrate, in fact, to about 100 milliosmoles, and slightly decreases the volume. So you can see that the osmolality is the highest at the bottom of the nephron loop, lowest at the very end of nephron loop, and kind of in the middle in the beginning. Now, the role of countercurrent exchanger is to take away reabsorbed sodium chloride and water. So blood that enters vasa recta from efferent arteriole, and I want to remind you the sequence of blood vessels that blood flows through in the nephron. It's afferent arteriole, then glomerular capillaries, then efferent arteriole, then in case of juxtamedullary nephron, vasa recta, and then postcapillary venule. So as blood goes into the countercurrent exchanger, vasa recta, it reabsorbs water and sodium chloride. So therefore, volume that leaves vasa recta is more than the volume that enters vasa recta. Before we move on to collecting duct, so blood volume here, the short answer, the blood volume in countercurrent exchanger increases. Does that make sense? Any questions? Okay, in the collecting duct, a facultative reabsorption of water occurs. Aquaporins are the proteins that allow water molecules to come across the tubular epithelium. Their number is regulated by anti-diuretic hormone, and as we already mentioned, this is a facultative reabsorption, meaning that it can be regulated. So if somebody is overhydrated, meaning that plasma osmolality is low, it's very diluted, ADH levels decrease, the number of aquaporins decrease, and facultative water reabsorption in collecting ducts decreases as well, which allows water to basically be excreted. And if plasma osmolality is high, meaning somebody is dehydrated, ADH levels, they go up, which increases the amount of aquaporins, so more water will be reabsorbed from the filtrate into the blood, restoring normal plasma osmolality. In this mechanism, in countercurrent mechanism, the urea plays the main role in stabilizing the concentrations in the medullary extracellular fluid to make sure that countercurrent mechanism can actually function. And urea concentration changes in the interstitial fluid of medulla the same way the filtrate concentration changes. It goes from 300 in the superficial medulla to 1200 in the deep. So far, any questions? Okay. So renal clearance. In a nutshell, it's the renal clearance shows you whether the chemical is, I'm not going to ask about the formula, so you don't worry about that. Whether the chemical is completely reabsorbed, freely filtered, or secreted, or incompletely reabsorbed. So, if a chemical is completely reabsorbed, say glucose in the healthy person is completely reabsorbed, its renal clearance is 0. So there's no glucose in the filtrate. If the chemical is not reabsorbed at all and just freely filtered, like creatinine, its renal clearance will be equal to GFR. If a particular chemical partially reabsorbed, its renal clearance will be less than GFR. And if a chemical is freely filtered and secreted on top of it, its renal clearance will be more than GFR. Make sense so far? Good? Questions? Awesome. So the pathways for the water loss from the body. Breathing, feces, sweating, urine. Breathing and sweating, there's not much regulation there. Same goes for loss with feces, but most water is lost with urine. So that's the one that is regulated. So how can we replenish water? By drinking it. So thirst is regulated by angiotensin from renin-angiotensin-aldosterone system and by ADH. When you are dehydrated, ADH is produced, increasing thirst. And usually when you're dehydrated, your blood volume goes down, blood pressure goes down, which triggers renin-angiotensin-aldosterone system, and angiotensin stimulates thirst. So you replenish. Now, this system, renin-angiotensin-aldosterone system, how does it regulate sodium content? We talked about it multiple times. When blood pressure decreases, the system is triggered, and aldosterone in the end increases sodium content in the body by increasing sodium reabsorption in the kidneys. Atrial natriuretic peptide does quite opposite. So atrial natriuretic peptide can respond to elevated blood pressure or elevated sodium in the body. So it will stimulate increased excretion of sodium. Basically, it will inhibit effects of aldosterone. It will reduce reabsorption of sodium in the kidneys, and sodium will be excreted. Main stimuli, obviously, for atrial natriuretic peptide: elevated sodium, elevated blood pressure. For renin, decreased sodium, decreased blood pressure. If you consume a lot of sodium, say, I don't know, 2 teaspoonfuls of sodium, if you eat 2 teaspoonfuls of sodium, the amount of sodium in your body, in your blood, will immediately increase. And as you remember, higher sodium, so sodium attracts water. So in response to elevated concentration of sodium in your blood, water will be immediately drawn from your cells into the blood and extracellular fluid. So elevated sodium will immediately lead to elevated blood volume and elevated blood pressure. So that's an immediate response to sodium consumption. And then you know that will trigger atrial natriuretic peptide, and your sodium content in the body will go back to normal. Questions about sodium regulation? All right, good. Main mechanisms of potassium level regulation. Direct excretion. Potassium is just filtered. The second mechanism is aldosterone stimulates potassium excretion. So basically you have two pathways. Okay, one is direct excretion, and another one is mediated by aldosterone. Potassium levels have to be very tightly regulated because they're usually pretty low in extracellular fluid, and the change in potassium levels can negatively affect the performance of your heart, for instance. Calcium reabsorption is regulated by parathyroid hormone. That's kind of it. Three major buffer systems: bicarbonate, phosphate, protein buffer system. Physiological role of a buffer system is to maintain pH. Bicarbonate system is by far the most important system in the extracellular fluid, and also plays pretty important in plasma. I'm not going to ask about the chemical reactions for the mechanism, so you can scrap it. Phosphate buffer intracellular in urine, and protein, plasma, and intracellular. Acidosis is more common. What can lead to respiratory acidosis? Dysfunction of the respiratory system, hypoventilation. Essentially, this is what now hospitals see in patients with the coronavirus, because their lungs do not perform pretty well and they develop acidosis due to the respiratory reasons. Respiratory alkalosis, hyperventilation. Usually it is not a permanent condition, it's temporary. Metabolic acidosis, diabetes, ketones, keto acids significantly decrease pH of the blood. Metabolic alkalosis, rare, can be due to the, metabolic acidosis, another reason for it, diarrhea. Metabolic alkalosis, vomiting, when you vomit out acidic content of the stomach, long-term vomiting, so you should try. And consumption of vast amounts of antacids, which usually people don't do. So hydrogen excretion in urine. Remember, bicarbonate cannot be directly reabsorbed from filtrate. So in the tubular cell, carbon dioxide and water combine, forming carbonic acid. Carbonic acid dissociates, producing hydrogen and bicarbonate. Now bicarbonate can go back into the blood, and hydrogen will go into the urine, and basically it's excreted. In the filtrate, hydrogen will bind to phosphate, and it will also bind to bicarbonate. When it binds to bicarbonate, it forms carbonic acid. Carbonic acid dissociates. CO2 diffuses in the tubular cells, and in the tubular cells, CO2 binds to water, and the cycle goes over and over again. So essentially, if you have increased hydrogens, more hydrogens will be excreted into the urine in this very indirect route. What happens to carbonic acid? No. Okay, very bottom. Okay, let's move it up. So in respiratory acidosis, concentration of CO2 in the blood goes up. Only renal system can compensate for the respiratory acidosis. So it will increase the diffusion of bicarbonate from the tubular cells, which essentially, quite interestingly, will increase the concentration of bicarbonate ion in the blood. In respiratory alkalosis, the responses are opposite. Because the kidneys will reabsorb less bicarbonate from tubular epithelium. Now, we are more interested in metabolic effects, so if there is a renal failure or diabetes, and there is metabolic acidosis, the concentration of bicarbonate goes down because it is used to compensate for this hydrogen. Now, since concentration of bicarbonate goes down, pH goes down, your respiratory system will attempt to compensate for it by increasing the rate and the depth of breathing. But when you start to breathe faster and deeper, the concentration of carbon dioxide in the blood will also decrease. And same with the opposite sign is true for metabolic alkalosis. Bicarbonate ion concentration goes up. Your respiration becomes less frequent and more shallow, and concentration of CO2 in the blood increases as well. So far, any questions? All right, excellent. 3 layers in the wall of ureters. Mucosa, muscularis, and adventitia, connective tissue. Type of muscle tissue, smooth muscle. Type of epithelium, transitional, so they can stretch. Ureters lead into the urinary bladder. Distal ends of ureters have sphincters. When urinary bladder pressure rises, distal ends of ureters close to prevent the backflow of urine into the kidneys. Urinary bladder walls, mucosa, submucosa, muscularis, serosa, epithelium, transitional, smooth muscle in the muscularis. Trigone is the area between the openings of the ureters and opening into the urethra, where infections occur most frequently. Male urethra is longer. Transitional epithelium is found in the most of the urethra, except for the very distal near urethral orifice, where epithelium changes into the stratified squamous from transitional. Efflux of urine from urethra is controlled by internal and external urinary sphincters. External is voluntary, internal is not. Internal urinary sphincter is controlled by parasympathetic nervous system, and external is controlled by somatic nervous system. You can control it consciously. In micturition reflex, stretch of the urinary bladder sends the signal to the spinal cord into the brain. Sorry, not the spinal cord, medulla oblongata. Sends to the signals to the medulla oblongata. Medulla oblongata responds with the relaxation of the internal urinary sphincter. So sympathetic system is inhibited, parasympathetic is stimulated, and when you are ready to urinate, you send the somatic signal to the external urinary sphincter to relax, and you can urinate then. Questions? Okay, good. Scrotum is connective tissue sac, skinny sac where testes are housed, two muscles that help scrotum to ascend and descend, dartus and cremaster. Physiological importance of these processes is to regulate the blood in the for the testes, so sperm can mature properly. So basically, when it is warm, testes descend to cool down. When it is cold, testes ascend to warm up. Cryptorchidism is the failure of testes to descend. They get stuck in the pelvic cavity, and that affects sperm maturation and may lead to infertility. Anatomical parts of penis: root, shaft, glans penis. Circumcision is the removal of the foreskin. Medical justifications for the procedure: it reduces the risk for sexually transmitted diseases. Internal structures, so you have corpora cavernosa and corpus spongiosum. Basically, those are sponge-like bodies that are filled with blood during erection. So the sperm is produced in seminiferous tubules in the testes. From seminiferous tubules, it enters straight tubules, retitestes, epididymis, vas deferens, ejaculatory duct, and urethra. We just described the anatomical path for sperm. So sperm is produced in seminiferous tubules. It goes in the epididymis where it matures. From epididymis, it goes into the vas deferens or ductus deferens, which is ligated, either tied or completely cut during vasectomy. So that's the way to, it's kind of, sterilization for the male. Three accessory glands: seminal gland, prostate gland, bulbourethral gland. They produce secretions that, together with the sperm cells, form semen, form sperm. So there are certain components. Fructose is the source of energy for spermatozoa, sperm cells, to move. Alkaline component of semen is needed to neutralize acidic urine that traces of which may be left in the urethra. Clotting factors allow sperm to clot in the vagina, preventing it from leaking out. And prostaglandins stimulate vaginal contractions. Questions? Okay, we're good. And prostaglandins stimulate vaginal contractions, promoting the sperm, ejaculated sperm from vagina into uterus and then into the towards the fallopian tubes. So bulbourethral gland secretion specifically produces the mucus that lubricates glans penis. So far, any questions? Okay. So mechanism for the erection, you have two. Overall, the sexual response, male sexual response and female sexual response, they are controlled by sympathetic and parasympathetic system together. So parasympathetic system controls the erection. Parasympathetic signal leads to the release of nitric oxide, which leads to vasodilation, relaxation of the smooth muscle, vasodilation of the arterioles in the penis, which leads to the expansion of corpora cavernosa and corpus spongiosum, and that leads to the engorgement and erection of the penis. In ejaculation, sympathetic responses, they stimulate smooth muscles surrounding ejaculatory duct and urethra to propel semen through the ejaculatory duct and urethra. And it is controlled by sympathetic responses. Now, there's a sphincter between the urethra and urinary bladder. During ejaculation, that sphincter that separates urinary bladder and urethra constricts. So sperm does not go into the urinary bladder, but is directed towards the urethral orifice. Spermatogonia develop into sperms. Spermatogonia diploid 23 pairs of chromosomes, and when they divide the very first time, very first time, they again produce diploid cells. But then daughter cells will enter the meiosis 1, and that primary spermatocyte, okay, it will produce haploid cell. Now, the product of that division is haploid cell with 23 chromosomes. And after the second division, after meiosis 2, you get spermatozoa, which are again haploid cells. So you essentially go from one diploid spermatogonia into 4 haploid spermatozoa. So 4 spermatozoa generated as the result of spermatogenesis, and they are haploid. Essentially, Sertoli cells, they guide the process of spermatogenesis, and they also form the barrier between the blood and the sperm, so there is no autoimmune reaction against spermatozoa. This barrier, as we just mentioned, is important, so there's no immune response, immune reaction, no possible autoimmunity against spermatozoa. Leydig cells, during spermatogenesis, produce testosterone, which is essential for this process. So the whole hypothalamus pituitary gonadal axis can be described as follows. Gonadotropin releasing hormone produced in the hypothalamus stimulates gonadotropins produced by pituitary glands. 2 gonadotropins are follicle stimulating hormone and luteinizing hormone. So follicle stimulating hormone acts upon testes, leading to the production of androgen binding protein, while luteinizing hormones stimulate the release of testosterone from Leydig cells. So testosterone binds to androgen binding protein in the Sertoli cells, and that binding stimulates spermatogenesis. So testosterone is produced by Leydig cells, ABP is produced by Sertoli cells. Testosterone and inhibin produced in the testes essentially establish negative feedback in hypothalamus pituitary gonadal axis in males. And interestingly enough, the more sperm is produced, the more inhibin is produced. So if sperm content keeps rising, like sperm cells number keeps rising, inhibin amount will increase, essentially inhibiting hypothalamus pituitary gonadal axis and slowing down the generation of fresh sperm cells. Now, if hormones, specifically luteinizing hormone and follicle stimulating hormone, are not produced in the sufficient amounts, testes will shrink because they will not receive the necessary stimulation through that axis. So effects of testosterone on metabolism. It's anabolic hormone. It stimulates the growth of reproductive organs. It increases the sebaceous secretions and stimulates hair growth on the skin, increases the bone density, stimulates muscle growth, and roughens up the vocal folds, lowering the voice. So far, any questions? All right. So female reproductive system, main parts, vagina, uterus, fallopian tubes, and ovaries. Function of ovaries is to produce secondary oocytes. Function of fallopian tubes is to convey secondary oocytes towards the uterus, and they do it by using cilia that are present on the epithelium of the fallopian tubes. The function of uterus is to incorporate fertilized ovum and provide a place for the fetus to develop. Function of vagina, it's a copulatory organ. Vagina is covered by stratified squamous epithelium. Now ovaries, cortex and medulla. Cortex on the outside, medulla on the inside. Cortex is the place where follicle maturation occurs. And medulla, mostly nerves, blood vessels, so on and so forth. Ovaries and fallopian tubes are not connected physically. They separated. So oocyte that is released from ovary during ovulation may or may not go into the fallopian tube, and if it ends up in the abdominal cavity, it's fine. It basically dissipates in the abdominal cavity. However, if for some reason that oocyte is fertilized and it does not end up in the fallopian tube, it is called ectopic pregnancy. Ectopic pregnancy is when fertilized ovum, instead of getting all the way to the uterus, ends up in the fallopian tube, or what's even worse, in the abdominal cavity. It's a life-threatening condition. Pelvic inflammatory disease is the result of many sexually transmitted infections when microorganisms migrate from vagina through the uterus, fallopian tubes, and spill into the pelvic cavity. That's a pretty bad condition. Now, endometrial wall consists of 3 layers: endometrium, myometrium, and perimetrium. Perimetrium is kind of boring connective tissue. Myometrium, it's a muscle, very thick muscle. Its function is to expel a fetus during the delivery. Endometrial layer, in turn, can be divided into stratum basalis and stratum functionalis. So stratum functionalis provides a place for the fertilized ovum for the blastocyst to be incorporated into the endometrial wall. And stratum basalis is necessary to regrow stratum functionalis every time after menstruation occurs. Now, male structures that are homologous to labia majora and labia minora are basically the scrotum. Greater vestibular glands and bulbourethral glands are homologous. And clitoris is homologous to penis. Glans clitoris is homologous to glans penis, and prepuce of clitoris is homologous to foreskin, the prepuce of penis. Mammary glands are modified sweat glands. Lactiferous ducts convey milk to the nipple. And the main source for cancer cells in the breast cancer is epithelium of lactiferous ducts. Risk factors: late pregnancy, early onset of menses, late menopause, and some genetics. It's important, like BRCA1 and BRCA2, it's important to remember that 70% of breast cancer cases are not associated with any risk factors. Ogonium, diploid. Now, it divides and it enters the meiosis. So primary oocyte enters the meiosis, and primary oocyte is haploid cell. So when, primary oocyte is diploid cell. Now primary oocyte enters the meiosis 1. Question? Okay. Primary oocyte enters the meiosis 1, and this process of generating primary oocytes starts in utero. And then when women, after the puberty, every month, primary oocyte completes meiosis 1, and it produces secondary oocyte, which is haploid. Secondary oocyte does not complete meiosis 2. Okay? Every month, basically every ovarian cycle, one primary oocyte completes meiosis 1, generating haploid secondary oocyte, which then is ovulated. And secondary oocyte completes meiosis 2 only if it's fertilized. And the result of fertilization is the production of ovum. It's actually very interesting. If you think about it, a lot of people say, oh, ovum or egg is released from ovaries during ovulation. No, it's not true. It is secondary oocyte that is released from the ovary during the ovulation. It doesn't complete meiosis 2 just yet, but once it does, that's ovum, but it does complete meiosis 2 only when it is fertilized. So it's not really correct. Well, we can say how many ova produced as the result of gamete development. So one oogonium, you have oogonium here. Yeah, one oogonium produces one secondary oocyte or one ovum. Okay? And that also yields 3 polar bodies, which disintegrate. Now, any questions so far? Okay. So, ovarian cycle, 2 stages. Follicular stage before the ovulation, that's the development of the follicle. Luteal stage, that's the development of an existence of corpus luteum. So, ovulation-ready follicle is called Graafian follicle or mature follicle. It contains secondary oocyte. And after the ovulation, that follicle turns into corpus luteum, which function is to maintain high levels of estrogen and progesterone for the proper preparation of endometrium in the uterus for the blastocyst implantation. So let's talk about the regulation of ovarian cycle in females. It all starts with gonadotropin releasing hormone produced by hypothalamus. It increases the levels of luteinizing hormone and follicle stimulating hormone produced by pituitary gland. Gonadotropins act on ovaries in females, and FSH stimulates follicular growth, while luteinizing hormone stimulates the release of estrogen. Now, interestingly enough, we have a negative feedback. So, luteinizing hormone stimulates estrogen, but estrogen inhibits luteinizing hormone. Okay? So that's that. However, since follicle keeps on growing, right here, growing follicle increases slowly but steadily, increases levels of estrogen. So essentially, estrogen levels increase because follicle grows and produces more estrogen. Now, when estrogen levels before the ovulation surge, it switches the system switches the feedback from negative to positive. So estrogen, instead of inhibiting luteinizing hormone, starts to stimulate it. So now, what we have is luteinizing hormone stimulating estrogen, and estrogen in turn stimulating luteinizing hormone. So in response to estrogen surge, luteinizing hormone surges. And when luteinizing hormone surges, ovulation occurs. Now, after the ovulation, corpus luteum starts to produce progesterone and estrogen. Both these hormones inhibit gonadotropins and gonadotropin-releasing hormone. Now, if the secondary oocyte is not fertilized, corpus luteum disintegrates. If corpus luteum disintegrates, the levels of estrogen and progesterone go down. When levels of these two hormones, estrogen and progesterone, go down, gonadotropin releasing hormone levels go up because it's not inhibited anymore, and ovarian cycle starts over. So how do gonadotropin levels change during ovarian cycle? They stay relatively low, although slightly increasing during the follicular stage. The levels of luteinizing hormone, and to less extent FSH, surge during ovulation, and then they keep declining till the next ovarian cycle. Now, for estrogen, the picture is slightly different. Estrogen is kept fairly low, although climbing up. During the follicular stage, it spikes during the ovulation. Then it declines briefly and goes up to more or less steady levels during the luteal stage of the cycle, because corpus luteum keeps producing estrogen. Progesterone stays pretty low till ovulation, and after the ovulation, progesterone starts increasing because luteinizing hormone produces pretty high levels of progesterone, trying to prepare endometrium for the implantation of blastocyst. So, menstrual cycle. Any questions on the ovarian cycle? Okay. Menstrual phase. So, during the menstrual phase, blood vessels that supply endometrium, first they constrict, specifically stratum functionalis. They constrict, which leads to hypoxia and death of the cells in the stratum functionalis. Then they dilate, and estrogen and progesterone levels during this phase, they're still relatively low. Now, then they dilate and blood washes away the cells from stratum functionalis. So that's the mechanism for shedding. And then when estrogen levels start to increase after the ovulation, that stimulates the regrowth of stratum functionalis. That is a proliferative stage of menstrual cycle. So estrogen is mainly responsible for the regrowth of stratum functionalis. So levels of estrogen are pretty high, levels of progesterone start to increase. And during secretory phase, levels of estrogen are high and levels of progesterone are high. So both hormone, mostly progesterone plays critical role during the secretory phase, because progesterone stimulates those nutritional secretions from endometrium that would support the growth of blastocyst if it's implanted. So estrogen and progesterone are pretty high during the secretory phase of the menstrual cycle. Now, if oocyte is not fertilized, levels of estrogen and progesterone drop. If it's fertilized, corpus luteum stays active and levels of estrogen and progesterone are relatively high. Effects of estrogen on growth: it stimulates the growth spurt during puberty, stimulates breast development, increased subcutaneous fat deposition, hip widening. It increases calcium deposition in the blood and decreases blood cholesterol. Any questions so far? fertilization anatomically occurs in fallopian tubes. The chromosomal enzymes in the head of the sperm cell needed to dissolve coronary deoda so the sperm cell can actually penetrate into the secondary oocyte. When sperm enters the oocyte, calcium levels in the oocyte spike, and that decreases the permeability of the membrane in the freshly developed ovum. So now there's only, so that prevents other sperm cells from entering the ovum. Only one. Basically, that sperm cell shuts the door closed behind it. DNA of the sperm cell and DNA of the ovum fuse and form a nucleus of that newly developed zygote. Fuse, I mean they mix up. They form homologous pairs. Fertilized egg is transported to the uterus by synchronous beating of cilia in the fallopian tubes. And if you think about it, any damage to the cilia in the fallopian tubes, any previous infections that formed scar tissue and reduced the number of ciliated cells, they will increase the risk for ectopic pregnancy. Because if cilia cannot properly transport the ovum into the uterus, ovum may start developing in the fallopian tube. So while the egg is transported into the uterus, it matures in the blastocyst. Blastocyst incorporates into the stratum functionalis of endometrium, and cells called trophoblasts provide a necessary nutrition for the freshly incorporated blastocyst. So eventually, growing placenta takes over the role for the transport of oxygen and nutrients to the growing embryo. Maternal vessels that take blood to and from placenta are placental arteries and placental veins. And the structures that surround placental villi are sinusoids. Now, blood vessels in the villi, the fetal blood vessels are. And umbilical arteries take the blood to the villi, and umbilical veins take the blood from the villi. CO2 from the fetal blood diffuses into the maternal blood, and that increases the pH in the fetal blood, which essentially increases hemoglobin saturation in the fetal blood. Now, CO2 from the fetus, saturation, not unloading, saturation. CO2 from the fetus decreases the pH in the maternal blood, and that increases hemoglobin unloading in the maternal blood. So we have double bore effect. Elevated pH in the fetal blood increases the affinity of hemoglobin to oxygen, and decrease of pH in the maternal blood increases the unloading of hemoglobin there. And on top of that, fetal hemoglobin has a higher affinity of oxygen, which makes the oxygen transfer from maternal blood into the fetal blood extremely efficient. Effects of chorionic gonadotropin it inhibits menstruation, stimulates the growth of endometrium, and chorionic gonadotropin kind of inhibits the levels of progesterone and estrogen. Especially it's important for levels of estrogen because estrogen can stimulate the contractions of the uterus, and you don't want that during the during pregnancy. Now, during pregnancy, estrogen stimulates the growth of uterus, breast, and genitalia. Progesterone stimulates the secretory activity of endometrium, inhibits the contractility of the uterus, and prepares the breasts for lactation. Preeclampsia is the condition, basically it's kind of accumulation of failure due to the increased blood volume. It leads to elevated blood pressure, increases sodium and water retention, leads to arterial contractility and decreased renal function. Decreased renal function in particular leads to the accumulation of toxins in the maternal blood, and also increased arterial contractility impairs the blood flow to the placenta, which can lead to the fetal hypoxia, and in preeclampsia, pregnancy, the premature delivery has to be induced. Eclampsia is basically preeclampsia taken to the next level, very high blood pressure, extreme accumulation of toxins in the blood, and often in eclampsia there's no way to save a fetus. Ovarian hormone that initiates contractions in labor is estrogen. So estrogen stimulates initial contractions. Contractions increase the pressure on the cervix of the uterus. Increased pressure is sensed by the mechanoreceptors, which send the signal to the posterior pituitary, which releases oxytocin. Oxytocin stimulates contractions, more pressure on the cervix, more oxytocin, more contractions, more pressure until the baby is born. Now, stimuli for the milk production. Essentially, baby sucks on the nipple, and there are two hypothalamic factors that are released in response to that suckling stimulus. One is prolactin releasing factor, and one is oxytocin. Prolactin releasing factor stimulates prolactin produced in the anterior pituitary, and oxytocin is released from posterior pituitary. So prolactin stimulates milk production, and oxytocin stimulates milk ejection. So basically a letdown effect. So when a baby sucks on the breasts, stimulates oxytocin release, which stimulates the contractions of the lactiferous ducts and release of milk. And same story, suckling increases the levels of prolactin, which stimulates milk production. But you need both of those, oxytocin and prolactin, to effectively produce and release milk from the breasts. Any questions so far? Okay, here you have the list of anatomical structures. I think it's pretty straightforward. Pictures, you will not see any other pictures in the exam. So this is basically same idea. I don't think it's any benefit to go over those questions. I strongly encourage you to go over those and try to answer these questions because that will help you to write the essay questions in the exam on Wednesday. Any questions before I stop the recording?